rehabilitation sites. And it's an opportunity to be in those clinical settings and work with clinical teams and think through learning health systems. So we'll share some of that work with you today. I also would like to mention that I'm also a member of the Quebec Support Unit and work with a lot of the members there to think through as well learning health systems and the development of the tool today. So I'm fortunate to have with me today Joanne Mosel, who's been also working with us on this project, and I'll let her introduce herself before we get into the presentation.
Thank you, Sara. Thank you, everybody, for having me here. My name is Joanne Mosel. I'm in Montreal. I'm a CPA by profession. The rare disease space was something I was thrown into, neurologically complex rare disease space, and this has been my motivation to be a patient partner. I'm currently a member of the CIHR SPORE Evidence Alliance, currently co-leading a scoping review on a research topic I submitted as a patient partner. In 2021, 3 research topics were going to be funded, and one of the 3 across Canada was mine, because I was really happy because it was very dear to my heart. I've done 3 courses in patient partnership, both from SPORE Evidence Alliance and through McMaster. Some of the work I've done is reviewing lay summaries and grant applications, evaluation tools for patient partnership. I co-created lay summaries for COVID, and I'm on a family advisory council for a major pharmaceutical drug trial. Back to you, Sara.
Thank you, Joanne. So we'll share with you our slides right now and go into a little bit more detail about the work that we're doing together. I'm just going to get this in slide mode. Okay. Oops. There we go. It should be in slide mode now. If you're not able to see the slide, somebody just let me know. So a lot of the work that we've been thinking through is working together with different clinical sites and sort of thinking about how can we work on accelerating, bringing evidence, ideas from different partners and that we're working with, whether it's clinical, patient partners, decision makers, and work together to accelerate integrating, evidence or research or new ways of doing things, innovations into clinical settings. And this is what led to thinking through understanding where are different organizations starting at and how can we work together to work from their place of readiness or preparedness for a learning health system. So just to review a little bit the background around this, and I don't think this is anything new for many of us, is that we know that when new discoveries are made or new innovations develop, that taking them into practice is relatively slow and inefficient. And that recently the term learning health system has been used as a way of asking the question, can we, through a shift in culture and thinking and combining both evidence and digital health solutions, work together and benefiting from the experiences already within a setting and within the partners that are working within that setting, accelerate the translation of evidence into practice. And it's a way of saying not doing it in sort of bits and pieces, but having a continuous integrated process of changing practice and integrating new ideas and evidence. And the question then becomes, how do you develop such a system in order to have impact? And how can patients, clinicians, and organizations work together to do this? And where are they starting from? And where do they want to go in order to achieve aspects of the learning health system? This work was driven by funding from the Quebec Support Unit, where there's a huge emphasis on learning health systems and working together to bring different components to support a learning health system. And one of those projects with the team of investigators that are listed here. Together, we're working on developing a tool in order to assess readiness for implementing a learning health system, and using that tool really in a formative way to work with family medicine groups and other clinical settings in order to use it as a way of guiding next steps of where they'd like to go to strengthen their ability to implement a learning health system. And this work was led by Hervé Chala-Vignon Zomahoun, who was a postdoctoral fellow at the time when we started this work, and he's still very actively involved. So essentially, building on the work of the Institute of Medicine and Chris Friedman, who he says he's not the first to coin the term learning health system. It did start before, but he certainly helped define through the collaborations with members of the Institute of Medicine and operationalize for us what a learning health system involves. So it's this idea of taking knowledge and working in a learning community in order to use the data and information and experiences of individuals within a clinical setting in order to identify problems and use data in order to generate solutions to those problems, and then have this continuous cycle of implementing, evaluating, and improving. And of course, learning health systems are at a systems level. By definition, they're complex. Certainly resources are needed, but just as important is the engagement and active involvement of different members of the organization. And those who bring in different levels of expertise and knowledge. And most importantly is working within what I guess we can refer to as real world environments or communities or local health organizations to implement and directly and work directly with members within the organization, and not have it as a separate part of activity that's going on outside. Now, what I'm describing can sound very much similar to quality improvement and the Plan, Do, Study, Act cycle. So what is unique about a learning health system? And this is something that Dr. Friedman wrote about in a recent publication, where he identified 3 elements that really distinguish a learning health community from any other quality improvement type of initiative. One of those is, the first one is continuity of collaborative execution, is that sometimes within an organization or within a hospital system, there are different groups who are responsible for different aspects of the learning cycle. So there might be those who are what we call the change implementers, who might implement the change, but they might be a separate group from those who actually are looking at performance to data or program evaluation, and also separate from those who do health services or research or help do the evaluation of new practices. They might be overlap in the members, but typically they often work in separate groups per se, and don't necessarily communicate with each other. And there's a handoff that he describes that might occur. And within that, information might be lost, but also commitment to solving the problem or identifying solutions or implementing it might be at different levels. And that's what he distinguishes from a continuous collaborative execution of a learning health system. So this idea that it's a group that is a learning community that work together through every step of the way of the learning cycle. And it's the same group that reflect and make decisions along the way in terms of addressing different areas that are needed for a learning health cycle, whether it's looking at identifying the problem, identifying what needs to be measured to say, is the problem improving, or selecting the strategy or the interventions that would be implemented. So that's one main difference between a quality improvement cycle and what we would call a learning health system. The other big thing is embracing uncertainty. It is the second piece that he refers to. So it's the idea that the learning community is willing to accept some level of uncertainty of what will come down the road, what potential solutions might be identified for solving the problem. And I might even say it starts one step close before that, which is uncertainty about which problem will be tackled first. And it's this willingness to work with the learning community to prioritize and then identify solutions and then enact any of the changes that might happen. But it's agreeing that while everyone's coming in with maybe some ideas and experiences of what might work, that the community is willing to learn together and adapt as needed based on new information or new learnings or interactions between them. And then the third one, which is really the piece that requires a lot of resources other than time, is providing a common infrastructure. And the idea that there could be multiple learning cycles that can be supported by the same socio-technical infrastructure. So it's not that each time a problem is identified that you have to start all over again of putting together the community and then identifying essentially technological infrastructure like data collection, expertise around outcome evaluation, digital health solutions that might help feed back some of the information. It's not starting from scratch each time there's a new learning cycle, but rather there are multiple learning cycles that could be supported by the same socio-technical infrastructure. And you can think of this within an organization. So one family medicine group, you can think of it within a health network, perhaps, that has the same socio-technical infrastructure. And then you start to get really larger economies of scale if it could be across several networks that are sharing the same socio-technical infrastructure and not reinventing the wheel, if you will, for certain needs around data collection or digital health solutions and so on. And possibly enlarging the learning health community where there might be one locally, but they're linked in to a larger learning health community across organizations or across a province or country or multiple countries. So this is where another important distinction of a learning health system is how do you achieve economies of scale by having this common infrastructure that's providing shared services to go through each of the steps that you would in a learning health cycle, from organizing and creating the learning community all the way to implementing and enabling performance change. So given the complexity and the many elements that are needed, one of the questions where we started at is saying, how do we work with teams and how do we work together to say, where are we starting and what's our level of readiness, if you will? And I always hesitate when I say the word readiness, because in the back of my mind, I'm reflecting, is this the best word? But we can come back to that later, maybe in the discussion. Is really trying to understand where are clinical sites starting at and how could we work together to say, where do we want to go? And could there be a tool to guide that process? So we undertook the steps to develop a readiness tool for a learning health system, where we did an extensive literature review. So now it's plus 60 publications in the past 2 years alone. There have been many articles that are published on learning health systems. If you search for that word in databases, you'll see that it exponentially increases over time. Based on extracting common domains and subdomains, we developed an initial version of the tool. And I had mentioned Dr. Zumahoon, who was leading this effort and work and had to do an extensive amount of effort to extract all of the domains and subdomains. And then we also extracted items. And there are tools that exist that are similar to the concept of readiness or similar to some aspect of evaluation in a learning system, but not directly getting at the readiness domain, and certainly not evaluating all of the different areas that we felt would be important to think about in evaluating readiness for a learning health system. Once we had that initial version of the tool, and Joanne will talk about a little bit her experience of looking at the tool the first time, and the need to really simplify terms and reduce the content, because it's 442 is quite a large number of items. So we had it reviewed by 2 patient partners, 6 researchers and clinicians and policymakers working in the area of either implementation science or learning health systems. and then went through an iterative revision of it, and really asking questions around relevance, exhaustiveness. Is there something missing? Is there something repetitive? And clarity. We then translated the questionnaire, and this is where we're at right now, where we have a draft of an English and a French version of the questionnaire. I'll talk a little bit near the end of our session about Adelphi that we're about to launch in the next month or so, and then some work that we would like to do around validation of the tool. To give you an idea of the questionnaire, and I'll go through various components of this before turning it over to Joanne. Essentially, we started with the 4 main domains that I presented earlier, and here you see definitions of those domains. I also shared an article that was shared with you in the chat, so you can always go and look in more detail at the definition of these broader domains of performance to data, data to knowledge, and knowledge to performance. And then there are some core values that are around policies, governance, regulations that are also important to consider in terms of sustainability and scale up of a learning health system. Within each of those larger domains, we then identified subdomains that we felt targeted each of these that would be important to evaluate. And so, for example, in performance to data, the steps of being able to prioritize needs. Once a need is identified, being able to define indicators or measures or outcomes of success of improving that area, or identifying areas that need further improvement. And then domains around data collection and the data collection process in order to be able to support performance to data. And then we did the same for each of the larger domains that you see here. We also shared a link that can take you to an infographic that shows you all of this, so you can go back and refer to it. And then within each of these domains, we then generated items that we felt covered the breadth of each of these subdomains. This is one example for knowledge to performance, where one of the domains is conducting an environmental scan, and we define what that domain is. So it's the ability to look internally and externally of the current state of a given issue or problem that's been prioritized. And then asking about the readiness of the organization to target specific aspects of conducting an environmental scan. So some examples of items, for example, are my organization or family medicine group has the needed expertise or external experts in order to identify the gaps with the associated determinants that influence that practice. And then the scale is on a 5-point Likert scale of agreement. And based on where they rate this, then you would get an idea of their level of readiness on that item. Now, you could imagine that each of these, are not cumulative in the sense that the idea is not to get a total score, but more to get a profile on different subdomains and items in order to understand where are their areas of strength and where are their areas that are not as strong, and then decide, is that an area that the family medicine group, for example, would like to work on? Is that a priority area? And so on. And you can look at this the same for evidence of synthesis, which is also under the knowledge to performance domain. These are just additional and maybe a slightly different type of domain, like governance, which is under the core values within our domains. And one of the questions, for example, is, does my family medicine group have a stable governance, including a vision and policies and a strategic plan? And then they rate the level of agreement with that. Now, even at this level, we recognize there's a lot of simplification of some of the items that needs to happen, and that's what the next phase of the work will be. It took quite a lot of revisions to get to this step because we are asking about several subdomains and often very complex ideas. And the question is, how can we simplify it and tease out what's the most important to ask within an item or a given set of items? So I'm just going to pause there and turn it over to Joanne to talk a little bit about her perspectives as a patient and public partner, and a little bit about her contribution and role in this project as well. So I'll turn it over to you, Joanne.
Okay, thank you, Sara. Well, my presentation is really framed around Dr. Friedman's article, and it's going to be really an overview from a patient partner perspective. This project itself I found very challenging. It's fairly abstract in a certain way from a patient partner perspective. I thought it was really clear and understandable even by me. And a lot of work has gone into it. But from the patient partner perspective, again, I just want to talk a little bit about things probably that have nothing to do with what Sara said, but maybe in the background of how do administrators work with patient partners. So building the relationship, Sara, please, next one. The basics of patient engagement. So it's about building the relationship, and this takes time. So it has to take intentional activities to take the time to build the relationship. Building mutual trust and respect, that's extremely important, and everybody must be aware at all times of the power imbalances that exist, and there's no getting around them, but to be aware of them can make a big difference. Be clear about the roles and responsibilities. Patient partners also have responsibilities, and as long as they're clearly laid out, then things will go fairly smoothly. There can be a lot of confusion. They're dealing with jargon, lack of just expertise and experience. And so constantly just, being available to answer questions, encouraging questions is always helpful. Ensuring clear and timely communication throughout. Check in even if the patient partners are not actively engaged at that particular time. It could go months. Very often these projects go on for years, and patient partners don't like to feel that they've kind of been dropped off. So just a quick check-in would be really appreciated. Actively and intentionally creating a safe environment. I would recommend acknowledging all input. The next slide, please. So the problem. So you now have all the overarching theory about the problem and collaboration to the end. And I would say, well, do patient partners agree on the problem that's been identified? I think there are already many disconnects between patient partners and learning and health systems. And so focusing on the problem, because that's, he mentions, focused on the problem, but make sure that the problem is what's been identified for patient partners too. And it's a question, is a goal to reach consensus? Maybe it's not, maybe you can't, maybe you can, maybe you can work towards it. For continuity, collaboration to the end, patient partners come and go, just as staff do. There may be lack of continuity because of that. They may lack the expertise to be involved in each phase, so that at that point in time, they may not be as evident of their presence, actually, but they step back, but they're still there. Has bias been identified when we have cultural impacts, especially now with many international students and faculty? Has that been identified? Is leadership consistent? Patient partners bring skills which may be present at different stages of the cycle. And leadership will keep everybody together. One of the projects I've been working on, even though it's gone on for, I think, 6 years now, some people have come and gone, but the leadership at the top has been consistent, consistently respectful, and sort of keeping it all together. Next slide, please. So uncertainty. So Sara talked about uncertainty. Yes, and patient partners live uncertainty all the time, especially in rare disease. What I appreciate when I'm in a group of people, whether I'm speaking or they're speaking, if I can say, I didn't know that. That makes my day. And if I hear somebody else says, oh, I didn't know that, well, that really makes my day, because that's part of the learning process that's been successful. A flowchart and audit. So for me, that's the P to D, the performance to data is like a flow chart, just from my accounting background. You make this is like it's a picture of all the flow of who does what and where everything is supposed to go. And patient partners can help make this meaningful when it comes to the data to knowledge, because you can have a lot of data. In my opinion, sometimes way too much data. There's wrong data. There's data that does not make any sense. And when you're asking patients and patient partners about surveys and things like this, and usually like they're enough already, it's something that should be, I think it's time for the data accumulation to be managed better if you're going to use patient partners. And of course, you have to do that. Then the knowledge to performance is the audit part. The patients can see if it really works for them or not. I think it's really easy to have the check boxes that everybody's busy checking off the check boxes. Yes, yes, yes. But really the meaningfulness is not there because they're not living that experience. Context. Well, context is sometimes almost everything. It should be local context. Cultural influences, again, there's a hospital here where there's a lot of Indigenous children who are treated there, and so they're including native food, which would be really important for them to bring something back to home for them. In COVID times, my experience was I was trying to get my child to be seen at the hospital, and I was told I was the only one allowed to be accompanying him. And I said, no, this is not possible. I need another person. And I kept getting no. And I kept saying, well, really, either I can talk to the doctor or I can take care of my child, but I can't do both. And I just kept it, no. And I was left with trying to decide, okay, well, do I cancel the appointment or do I go up the chain somewhere? I went up the chain somewhere. Eventually it worked out, but it was not a pleasant experience. Not for any maybe policy reason, it happened that way. So these are things I think that patients in the hospital deal with constantly. And it's important that their voices be heard. Premature closure, there's always time constraints. It's good enough. Yes, at a certain point, yes, you have to say it's good enough, but for whom? So it's just something to keep in mind. And understanding patients is hard. I think, I wouldn't want to do that myself. Very difficult. Next slide, please. For the infrastructure, policies. So what are the established policies? What are the priorities? And what are the priorities for patient partners? This is an area I felt is the most critical for patient partners to be involved in, is to develop the priorities. Because if their priorities are not number one, they're not the policy, nothing else is going to follow. For instance, this is going back to the early days sort of patient partnership, when I attended a group of a reading club on patient partnership, and all the other researchers were reading documents that had been written by researchers. So it was researchers reading old research, and I was the only patient partner there, and nobody was interested in talking to me. And research and stakeholders on significant health issues where there's no patient partners. I'm still seeing that today. Let's get all the stakeholders on the table. We're going to deal with this extremely significant health issue, and then there's no patient partners. I don't know why. Again, I think it's a cultural thing. People are the wild card. We can have people that micromanage. We can have power imbalances. And there can be an environment of fear. And I think if patient partners are going to be part of the team, there can be no element of fear and a fearful environment, because it affects all the dynamics in the group. In terms of processes, I find usually they work. but we still have silos, and the silos are really challenging, I think, for everyone. And the processes, I believe, are a function of the policy and the people. So that's where we have to work on the policies and the people. Tech supports. I think technology will revolutionize primary health care. I'm sure everybody does. Like blood testing can be done at the local pharmacy instead of forcing patients to travel with 20 kilometers to their hospital just for simple blood tests. Blood pressure machines that are now available to in-home, respiratory care. There's so much in the research section that's still not available. It's not accessible to patient partners, and that would help everybody. It would take support, take the pressure off. So that's been really slow. I think that's Sara how started this her presentation. That everything is so slow, so patients really feel it. There will need to be training for healthcare providers and patient partners on. I think more and more training is going to become more and more important because I've always felt managing our own healthcare is really critical, and everybody needs training on how to do that at the technical aspects for the healthcare providers to be able to translate what needs to be done, and the patients to learn how to manage and do all the coordination that's required. Again, in rare disease, there's many specialists you're going to see. Okay, consequences of no infrastructure would be, for instance, you can have great policies like feasibility studies to be commissioned, and if they don't go anywhere, then that's a waste of resources. You can have a report 50 pages long that was commissioned because there was a problem, there was consensus on the problem, and the feasibility study was done, and it was just too long for anybody to deal with it, and that kind of just went there. So then we're just my comments on the Learning Health Survey environmental scanning. The patient partners can help identify the current state. I think they would play a critical role because they have insights of using the system and their lived experience all the time in the evidence synthesis of the best practices through shared learnings. Again, because of the internet, they're sharing their knowledge that they've gained from globally. I know my own experience. So my child was just diagnosed recently with a cerebral visual impairment. This is something that's misdiagnosed and misunderstood by many healthcare professionals, teachers, educators, everybody. And even when I went for an assessment for services, the assessment was based on incomplete criteria. So, and this I found out again from other learnings. Then in the learning health system, the core values, the governance, patient partners have a lot of skills. They're coming from perhaps they've been on boards, they've been in upper management, they have multidisciplinary experience, partnerships, they have resources. Patient partners can bring in a lot of resources in terms of philanthropy. There's the Opal, which is an app that was developed by a patient who had cancer, and she saw that was extremely inefficient for managing all the appointments and the tests and everything. And she was instrumental being an IT professor in helping to develop and create this app, which is now being expanded across, it's going to be across many domains, not just cancer. So this is my last slide, is another great question, just because Joanne has very few answers to all this, but everybody tells me, well, Joanne, that was a really good question you asked. So here's my question for you. Managers are often rewarded for managing and maintaining the status quo. How does one reconcile this tendency when implementing a learning health system in which change will be implicit? Thank you very much.
Thank you, Joanne. Yeah, so this has been the value of having Joanne and other health patient partners with us in this project, because you can see that she brings a very different perspective on all of these domains and subdomains. If we come at it from an academic or a research perspective, or even clinician, the way we see these things is from a very specific set of experiences. And so, what Joanne has clearly identified are different elements that patient partners can bring, and sort of the do's and do nots of engaging patient partners in this process. And Joanne started off by saying it's a very complex project. Absolutely. We're really thankful to her and others who have taken the time and to really look through the domains and the subdomains, because it has helped simplify things tremendously. And thank you for your question, Joanne. I think this is the age-old question of, and this is where, why learning health systems bring in this idea of culture change, and part of that, is incentives, and part of some of the questions or items in the learning health system readiness tool does get at incentives. So we do want to leave time for discussion, and possibly if anyone has answers to Joanne's question. I just wanted to end off by saying that I had mentioned our next step is to share the tool widely with the network, so we can conduct a Delphi in order to really narrow down what are the most important and relevant domains, subdomains, and items, and to work on the clarity of the items. So, and we'll have 3 rounds to gradually get at consensus, as close to that as we can. Part of it is the content, but part of it, if we can, by the 3rd round, we'd like to get at the implementation of the tool and really thinking about how it can be useful in different clinical settings and family medicine groups. So I'm going to end there, and we can open it up for questions or comments or thoughts. I guess I'll hand it over to you, Jamie.
Thanks, Sara, and thanks, Joanne, for both of your enlightening presentations today. It's great to have you, so thanks again for joining us. So we have, at this point, we have 1 question. So we do encourage you all to type in some questions in the Q&A section of the webinar on the bottom of your screen. The first question we have here is from Crystal Binns. How do learning health systems differ from practice-based research and learning networks? Or otherwise, we call them as an acronym, PBRLNs. So, Sara, did you want to take a crack at answering that first, potentially?
Sure. I mean, I don't know if I have the complete answer, but I'll tell you what my thinking is at this stage, because when I entered, the literature on looking at learning health system and discussing it with different groups and patient partners and clinicians, is that we are taking a lot of elements of what already exists around improving practice, bringing together people to think through questions and problems and finding solutions. What the sense I get is perhaps bringing in the learning health system is helping operationalize some elements that are important to put in place that maybe we knew implicitly but didn't discuss or measure or consider explicitly. So this idea of bringing together digital health, evidence-based practice, and culture change together, and really thinking through what's needed, I don't think that's new. I know that, in learning communities, in practice-based research, at different phases of creating those networks, these questions come up. And the learning health system literature seems to bring it all together in a way that is a bit different than before, and thinking more explicitly about what are the factors that impede being able to successfully put in place a learning health community. And then when I talk about those elements explicitly, like some of the domains that you saw there, or subdomains, is thinking through strategies for addressing those areas in order to think long-term sustainability. So that idea of having a shared infrastructure, as one example, where you can have multiple learning health cycles that are supported through a common infrastructure. And that could be obviously technology plays a big role in that, but it's also the people and having access to the same group of expertise of people to help you think through, measures or outcomes or indicators, for example. So it's that continuity, I guess those three elements that I presented early on of what distinguishes a learning health system that are explicitly targeted and addressed would be what I suggest is different. But we often do recognize that there's overlap with what already has been termed practice-based research networks, and especially a lot of elements of implementation science play a big role here. There's a lot of overlap.
Thanks, Sara. Joanne, do you have anything to add to that question potentially?
No, although I'm really happy that the question's being asked, because I hear a lot about quality improvement. But it's a theoretical, at a theoretical level, it's discussed. And again, I like the patient partnership literature that's around. There's not a lot of context. Not a lot of detail, not a lot of how do you do that? What does it look like? What are the actual steps in this context or in that context? So yeah, that's what I like about this survey, is that there's accountability to it, and it's clear, and it measures. It's not just sort of, well, quality improvement and there's no infrastructure for it.
Great. Thanks, Joanne. And yes, actually, this question that Mary has in the Q&A is really building on this. How would you approach a learning health system when we lack data to inform thinking differently? And her question is really about putting forward measures prior to understanding what we need to measure. Sara, what?
Yeah. So I'm assuming, and I don't know from the way the question is posed, but that it's maybe I don't know if you imply it in a sort of a negative light, that you wouldn't want to measure something if you don't know what what the problem is or what you need to measure. So I'm going to just take a step back and say that I think that's where, the first part of the learning health system is really that consultation and prioritizing. It's saying, where is there, where do we have areas that we need to work on? How do we prioritize them? And then work towards the measuring. So the idea of measuring, unless you know at least what target area or problem we're talking about, is difficult, and I would say maybe even unethical, in the sense that we're collecting data that we don't know how we're going to use it. So I don't know if that's where the question is coming from, but I think that approaching a learning health system before we get to the data piece is, what question are we trying to ask and what problem are we trying to solve, and then mapping through what would be an indicator of improvement for us, and based on that, then decide what do we measure. I think that's really important, to have that initial consultation and reflection before moving to measuring. So I hope that targets a question. I'm not sure if that's where it's coming from, but.
Oh, if I can just add, one of my favorite stories is from the great patient partners in arthritis research. They're so fantastic. And they talked about how research was being done based on inflammation of joints. So there was a lot of research, a lot of resources that figured that the point that patients were very concerned about inflammation in their joints. So, and then they spoke to patients. Afterwards, they spoke to patients. They said, well, actually, it's not that really, that's the worst part. It's the fatigue that comes from the pain of arthritis. So I just thought that was really highlighted. Okay, so whose priorities were being used as a basis for this research? Like, that was huge.
Absolutely, that's a great example, Joanne, and that's where that that discussion and really hearing and listening is extremely important, because that can change completely what's measured.
Thanks, and I actually have a question as well myself, and I thought I would just before we get to Viv's question. So I think that this is an interesting tool, and it's timely, I would say, because as a network, we have an objective to create a learning health system and patient-oriented primary care research. And we have this dynamic between socio-technical. So we would like to create a primary care information system on the technical side, a pan-Canadian primary care information system, and then also, really support our practice-based research and learning networks as well for the socio piece of that socio-technical infrastructure. So Sara, what do you envision the next steps for this tool within our network? And also, how important I get the sense that it's really important to have baseline data, within each of these PBRLNs to kind of get a sense of what areas they might need to improve in, et cetera. So could you maybe elaborate a bit on that, please?
Yeah, absolutely. I think, well, first of all, you've just, portrayed an excellent example for testing the tool and really understanding where is it going to work and where areas that maybe it's not going to work as well and we need to improve. So I think the first one is what I talked to. So just getting input from the network of what's relevant in the domains and subdomains and items, I think is a great start. And then the second is actually using the tool to evaluate and see, does it really provide that guidance of what you talked about, Jamie? So where are you starting from? And it will be interesting because I imagine within the large network, there are subgroups maybe that do work together. Usually most networks have something to that effect. Maybe it's a local family medicine group or a certain research network within the larger network. And that's usually how these larger groups are formed. And, can it be used? And I think this comes back to the very first question that was asked about what's the difference between a learning health system and a PBRN or a learning health network is, can you address those items that we have in the domains and subdomains and items at the large PBRN network level? And if the answer is yes, I think that's going more towards a learning health system or network, if you will, where the PBRN can support multiple learning cycles, right, within your network. So I guess in that sense, it could be used that's the hope, is that it could be used as sort of a ruler for saying, how good are we getting at having this shared socio-technical infrastructure and community that can think through together to address common problems, and then go through that cycle of, look at the data, decide where improvements are needed, choose new practices, put them in place, and keep going where there is that continuity, right? And that's what I've experienced in being part of large networks, is often you do lose that continuity. And so explicitly thinking about how to maintain that, either through, tools or training or historical knowledge that's kept and shared, but finding ways to do that, I think, is one way of applying it to the PBRN.
Thanks, Sara. Yeah, and as you described in your presentation and in your answer, it gets complicated very quickly. And so I think that there's a lot of potential here, certainly. So Viv asks, measures are important. However, where do the needs of the peoples in the community being integrated into the tools fit? Joanne, do you want to start with that, please?
Yeah, I love that question. Again, I think it harkens back to the basics of patient and public partnership. Building a relationship, having respect, but how do you actually get in the door? And I find it's something that's not really identified very well. That's where I started back in 2017 when I was in a group and somebody said, oh yeah, I walk into the hospital and I'm on this advisory committee. I thought to myself, well, how does that happen? How do you do that? So, my experience, it's been very small stepping stones. I had the time, and I had the great interest. And so when the opportunities came up, I jumped on them. Not everybody can do that. So again, it comes back to the people, the wildcard people of who are the leaders, by the PIs, whatever, for whatever reason, whether they're forced to or they're really interested in hearing from patient partners. There has to be like a networking. Right now, it's kind of in its infancy, I think, but we have things like the Pan Patient Advisors Network. There's a certain number, which is across Canada. Then there's certain, I think, in partner groups in different provinces. I mean, globally, we're talking about what Roche hosts, the international organization, I think of, it's IEP, International Experience Exchange of Patient Organizations. So this is globally. So there are more platforms to voice, to meet. It's there. It would have to take just concerted efforts. Actually, it's not that difficult if you want to incorporate patient partners in this tool to go through the SPOR Alliance, the Evidence Alliance. It's I don't know. I would like to see patient partnership really be developed as a science with credentials, really a lot of infrastructure. Or now it's a lot easier than it was. And you have advisory groups in many, I think, on many hospitals. So you have to seek them out, perhaps, but there should be like a registry. I'm not sure if that answers your question. I'm sorry.
Thanks, Joanne. I think it does. It touches upon some important things here. And even in terms of our network, we have a Pan-Canadian Patient Council of members, patient partners across the country in each jurisdiction. And we also are in the process of creating a policy hub of policymakers from across the country. So I think what you're touching upon is really important to, how maybe there's some room for adapting this tool and getting some feedback from important groups. It does sound like your team is comprised of many of these important partners, though, Sara. So I don't know if you had anything to add to what Joanne answered.
No, I think Joanne touched on all the important points, and it comes back to making sure we include those different community groups exactly the same way I described for the PBRN, right? And providing feedback on the content, but also applying it and saying, does it work in their context? And if not, do we need to ask it differently? So that is a question we keep asking. If it's used by a community learning organization, let's say, like a patient advocacy group, for example, or a network of YMCAs who also are part of the learning health community. They play an important part in healthcare and in health and social services in different ways. Would we need to adapt such a tool from their perspective rather than use the exact same one that we might use in a clinical health organization? So that's part of the questioning that we're going through right now.
Thanks, Sara. We have about 2 more minutes. I would love to at least answer maybe one of the 2 questions that are in there. So let's see. Bethany asks, I noticed on the PCHI lab website, there's a learning health system toolkit. Is this a work in progress? The links don't seem active yet. Excuse me. This topic is very timely for me, and I'd love to learn more. Sara, do you have anything?
I'll make it short. Yes, it's to come. It's to come. We have Dennis Radman in our group who's great at taking what we're thinking out loud and putting it on our website. So he's just getting ready to take what we've been discussing and help us package it in a useful way on the website. So it's to come still.
Great, Sara. And one last question here. In your research, what or who have you identified as being most mature in operating as learning health systems in Canada, US, or beyond, particularly that involves primary care?
Oh, you're asking me a tough question. This is like being at the Oscars and forgetting to mention someone. There are a number, and maybe we could share those offline. And I would say, and I believe the organizations we've worked with, we can share a few examples of publications where they've actually described their learning health systems in detail. And I would say that everyone would tell you most likely, we haven't completely identified or solved the problem, but we're almost there. So there are certain CISs and CIUSs, which in Quebec is our health regions, that are thinking of a lot of the elements that are in the tool that we identified, and including in their primary care as one of the perspectives. But in terms of putting all the elements in place, a lot of them say, well, this is the area that we would need to improve. I mean, Kaiser Permanente is a good example in the US, right? I think we, in Cleveland Clinic as well, where they have really great examples of how they've put in place the use of data. And as you know, in the US, having the electronic health record a little bit more mature is an example of having sort of that technical infrastructure, at least, that helps facilitate and accelerate getting to the socio-technical and the full learning health system model. But if you'd like specific publications and examples, we can share those with you.
Okay, great, Sara. Thank you so much. So we're 1 minute over. I'm just going to let everyone go, but just we have another CPCRN learning series session on April 18th, same time at noon Eastern Standard Time. This one will be a consultative session regarding, kind of building our equity, diversity, and inclusion work across the network. So we're going to have some of our EDI specialists present and presenting some of these ideas and facilitating a conversation about this. So please join us. And we also have an evaluation. Once I end this session, please complete it for us so that we have a better idea of what we can improve on. And have a great afternoon. Take care, everyone.